Good morning, everyone. Kwe, bonjour à tous et à toutes. Algonquin College would like to acknowledge that today's event is taking place on the unceded and unsurrendered territory of the Algonquin people. Traditionally known as Anishinaabe, Algonquin people are the original inhabitant of the wide expanse of territory along the Ottawa River. Good morning, my name is Claude Brûlé, and I'm the president and CEO of Algonquin College. It's my distinct pleasure to be your host for today's virtual Future of Health and Wellness speaker series. And what a beautiful morning it is. As I mentioned at prior events, many of us have had the chance to change the way we do business because of the pandemic. And this also applies to how we run events as well. Unfortunately, we're not hosting this event on our campus at our beautiful restaurant where we would normally eat a delicious breakfast prepared by our students. However, we want to make sure that we continue our dialogue with our community. I have just a couple of housekeeping items before we get started, as we have changed our platform to a webinar. Just as an aside, you can see and hear the panel this morning, but we cannot see or hear the attendees. If you have any general questions or you need technical assistance, feel free to use the chat. Our events team will be able to help you there. We also encourage you to use the chat to spark conversation with everyone here this morning. We also have a closed caption feature available. You simply have to click it on the appropriate button at the bottom in the Zoom app. And if you have a question for our speaker, there are two ways you can ask. You can raise your hand in the participants tab, and I will call on you to speak. You will then need to unmute yourself. Or alternatively, you can ask your question by typing it in the Q&A feature that's again in the Zoom tab. And I will read it out loud, and then our guests will answer the question. Also, feel free to share the conversation on social media using the hashtag ACHLE and hashtag ONHealth. So here we are with a slightly modified format for our virtual Future of Health speaker series. This event continues to be the place to share ideas, spark conversations, and discuss matters of relevance to the future of health and wellness across our community. Before I go any further, I'd like to acknowledge the presence of a number of community stakeholders who have joined us today. We have Keith Eagleye, City Councillor for Ward 9 and the Chair of Ottawa Public Health. Good morning, Keith. We have a number of Algonquin College Board of Governor members with us this morning. Andre Obonswin, Audrey Lawrence, Gail Beck, Ikram Zouari, Jay McLaren, Rodney Wilson, Stephen Tudor, Valerie Saya, and Wayne Johnson. Welcome to you all. Thank you for joining us and participating in our Future of Health and Wellness speaker series. We're always happy to meet our community neighbors and welcome you to our events. I also like to thank our partners at Bruyère and Ottawa Public Health for their engagement in this speaker series. I see that Guy Chartrand, Heidi Svestrup, and Peggy Taillon have also joined us this morning. Welcome and thank you for your continued support. So let's get started. Can't believe that it's already at our 26th installment of this series. 26, unbelievable. And as always, we have a meaningful morning planned for us today. We're honored to host Amy Hsu, PhD investigator at the Bruyère Research Institute, affiliate investigator at the Ottawa Hospital Research Institute, and faculty member in the Department of Family Medicine at the University of Ottawa. There are several key topics that we will be discussing with Amy. And so, as I mentioned earlier, a slightly different format from past breakfasts, where we've had a more formal presentation, then followed by questions. Today, we'll be encouraging you to ask your questions throughout the conversation that I have with Amy. And to set the stage, today's discussion will be more fireside chat format. So Amy will be discussing the impact of COVID-19 on long-term care, what we've learned, and ideas for future research. I will now introduce Amy formally. Amy, as I said, is an investigator at the Bruyère Research Institute, and she holds a University of Ottawa Brain and Mind-Bruyère Research Institute Chair in Primary Health Care Dementia Research. Her research focuses on understanding the care needs of older adults across the continuum of long-term care from home care to end of life. Recently, she held the development of a national report examining the impact of COVID-19 on residents in Canadian long-term care homes. She also represents Canada in an international collaborative led by the International Long-Term Care Policy Network, or ILPN, to compile data on COVID-19 in long-term care homes from over 25 countries. Thank you for joining us today, Amy.
Thank you, Claude, for the introduction and the invitation to be part of this Future of Health and Wellness speaker series. So as you mentioned, I think it's hard to believe that we're just days away from when COVID-19 was declared a global pandemic. And I still remember the very first week when the declaration was made. I think we had approximately 10 or 20 cases in Ottawa at the time, and no one could imagine the speed at which the transmission could have escalated in our communities. And I have been involved in long-term care research for over a decade. And at the start of this pandemic, one of the messages we kept hearing repeatedly was that older people with comorbidities were particularly at high risk of experiencing severe outcomes, acute outcomes from a COVID-19 infection. And of course, as a long-term care researcher, I knew that the population in long-term care would be particularly vulnerable to the severe outcomes if they were to become infected. And in fact, just weeks before it was declared pandemic, I had published a paper where we looked at the temporal trends of the sociodemographic and health characteristics of residents who are newly admitted to long-term care homes in Ontario over 15 years. So over the last 15 years, what we saw was that the proportion of admission or newly admitted residents who are over the age of 85, had increased by 10%. So that's almost an incremental increase of 1% per year. Yeah. And the number of residents who are admitted to long-term care homes with 7 or more comorbidities had doubled over the last 15 years. So when you think about what it means for this population and the impact of COVID-19, it wasn't a surprise to me that long-term care was so devastatingly and hardly impacted by this pandemic. And at the time, I was curious when we were seeing these counts of cases come out. I was curious about the number of cases that were actually reported long-term care. And to my surprise, there wasn't a lot of sources, the formal official counts of the number of cases in long-term care. And so in your introduction, you mentioned this national report, and that's actually when my research team and I started compiling data from news sources. We were listening to daily public health updates from across the country, both at the provincial level, at the regional public health level. So we were tallying the counts that were coming out of long-term care, and that's the data we had used to publish our first national report looking at the impact of COVID-19 on the sector. And I think in our first report, we had just over 1,000 cases in long-term care Ontario. And when I checked yesterday, we're now over 21,500 cases within the last year. That
is significant. So, and I recall myself a year ago when the numbers started to trickle in that we didn't see the latency effect that this would have. First, you see the number of reported and confirmed cases, and then you see slowly but the impact that it's having on our older population as a latency effect, and the hospitalization and the unfortunate deaths that have ensued. So, Amy, I guess what are some of the lessons learned from the first wave? And of those, what have we been able to incorporate in the long-term care environment so far?
Yeah, we definitely know that this is a multifaceted problem, right? I think one of the first observations was that outbreaks in long-term care were really concentrated in urban centers. And that's not a surprise, since urban centers, with the population density, with the propensity of people traveling through city centers, individuals in urban centers are more at risk of being exposed to community transmission. And of course, long-term care workers who are interacting with their communities, who are going in and outside of these long-term care homes. And at the time, many of them were working at more than one home, have unfortunately became the vector for this virus to be transmitted in long-term care settings. And that continues to be the case today, and which is why long-term care populations, both residents and the workers, have been prioritized in the administration of the COVID-19 vaccine. And one of the policy measures that were implemented at this time, which was to limit the transmission of the virus from home to home, was to restrict long-term care workers to a single site. And that restriction, I think, has brought to light for the general public the challenges that providers in the sectors and researchers like myself have known for over a decade, which is the challenges with staffing shortages, the challenges with supply in this workforce in the long-term care sector, and the precarious work arrangements that we've seen within the sector. Now, that's not unique to long-term care. I think many of us experience similar challenges in other sectors, but really the impact of COVID-19 has highlighted some of these issues within the sector. And what we learned was that from a public health standpoint, these measures have been effective. And so because of the single site restriction, actually in the analysis that my team and I have done, within about 2 weeks of that restriction being implemented, we started seeing the growth rate decline significantly. The growth rate was approximately, I think, about 12 to 15% prior to the restriction. And as soon as the restriction was implemented, it went down to 5% within a week, and then about 2% the week after. And since then, the growth rate in long-term care has actually been at a lower rate than the community. So the number of cases that increases every 7 days, it has been at a lower rate than the community transmission. But unfortunately, we know that this has also added additional stress on the sector in terms of the supply of workers, in terms of the support that we have to provide to this workforce. And we see this so clearly in Quebec, where because of the shortage of supply, and in the UK as well, they couldn't really make this a mandatory policy. So they couldn't mandate the limit to multi-site work in their province, just because if they had done that, they would lose a significant part of their workforce and actually create, I think, more opportunities where the sector and the care we can continue to experience gaps in care in the sector.
And do we see a difference between public and private homes in this regard?
Yeah, certainly. I think with studies that I've been involved in, and also what we've seen out of the Ontario staffing study in long-term care, is that generally we do see that public homes, especially the ones that are owned and operated by municipal governments, they tend to have higher staffing level. And what that means is that, of course, with more staff available, if someone to become sick, then you have the capacity to continue the care that you provide. Mm-hmm. And the other interesting thing was that, I think we were seeing a lot of acute care involvement in long-term care initially. And what happened, and we observed this in several homes in the GTA, what happened was that when there was a rapid influx of worker into the sector and there wasn't adequate PPE, in many of the homes that received outside help or additional help, they actually saw a spike in cases as a result. And so I think it actually takes a lot of planning to think about how to bring people into long-term care and the training that's required, because it's a complex population. You have a high proportion of residents living with dementia, and it's not easy to provide care for them. I hear that from workers who have been in the sector for 20, 30 years. So for someone who's only been there for 2-3 days, it is actually quite a bit of a steep learning curve.
Indeed. Okay, let's pause for a second here and see if we have any questions from our audience. So you have, again, as I said, you can raise your hand and I will call you out so that you can, somebody tried their hand there and it came and disappeared. So don't be shy. If you have a question, just put up your little blue hand and I will call you out so you can unmute. And there we go. We've got Claire Checklin. Claire, go ahead and unmute yourself and you can ask your question to Amy.
Hi there. I'm wondering if you can talk a little bit about what We've done well or not as well in terms of ensuring the mental health and well-being of the older adults in long-term care, and complementing that with restricting the spread of infection, especially keeping in mind the shortage of staff. So, and the sort of closure or pause in services that are usually offered in long-term care to help maintain routine and consistency and independence and things like that.
So thank you for the question, Claire. I think that's an excellent point. And we know that actually social isolation, anxiety, and depression are all known risk factors for dementia. And so with social isolation that had occurred over the course of the pandemic, I think thinking about the mental well-being, but also the physical well-being that could result from that in this population is something that not only I think many researchers have started to look at over the course of the pandemic, but they'll continue to look at the downstream impact of the social isolation. So I think in terms of course, there's always more that we could do. In terms of what we've done well, in the sector, I'm seeing a lot of innovation. I think, a lot of people in long-term care are looking for ways to improve resident care. And that occurred before the pandemic. I think thinking about resident well-being, thinking about mental health and support for the long-term care sector there's been ongoing work in that area. And I think it will continue to expand. I think we'll continue to expand on those programs. But what I was really encouraged by was the number of innovative ideas. I think, iPads are not the best solution, I think, to help to, I think, address the issues with social isolation, but it's one of the solutions that has helped older adults in long-term care stay connected to their family members and their loved ones over the course of the pandemic. And I've seen staff go out of their way. So I've seen many frontline workers actually end up spending extra hours in the home beyond their shift to help with the connection. So helping the residents set up on these iPad chats with their family. There's a lot of innovation around design. So thinking about how we're designing long-term care so we can continue and actually enable engagement in social activity within long-term care homes, but design in a way that we can maintain physical distance between the residents, but still allow them that interaction with each other and also with the staff members. So we're seeing a lot more of those ideas and innovation coming out of long-term care, which I think is encouraging because I think many of these innovations will have implication in the post-pandemic period as well.
Thank you.
Indeed. Thank you, Claire, for your question. And certainly that's something that we've seen trying to fight that sense of isolation that our senior population has. Very, very difficult at times because they want to talk to their loved ones and not always possible. Certainly when everything was really restricted and shut down, that became a very difficult challenge to overcome. And certainly there's a lot of work to be done in that regard. Amy, how did trends differ across jurisdiction? And we know that we've gone to a regional approach here, and that we have different guidance provided by public health units, measures implemented by government. So across jurisdiction, do we see any trends in what you've observed?
Mm-hmm. So certainly, I think one of the policies that has been at least considered across all jurisdictions was the single site work restriction that I had mentioned earlier. There are some provinces who have made it mandatory, and there are some provinces where it continues to be a recommendation. And what we've seen from the data coming out of the provinces was that the jurisdictions where they've acted more quickly in implementing some of these measures, they've been able to maintain the growth. So reduce the growth and also maintain the growth rate at a fairly low level. And this is the case in British Columbia. I think they're one of the first ones to introduce the single site work restriction. And in fact, BC is one of the only provinces that have factored in consideration for the risks that healthcare workers and long-term care face. So what I mean by that is that there's a health risk of working in this environment. So, I think early on we talked about the provisions of pandemic pay. And that is really to account for the fact that essential workers have to take on this additional risk by being, putting themselves to provide a service to the public, to the residents, putting themselves at risk, greater risk of exposure. So pandemic pay sort of accounts for that health risk that we're talking about. But there's also an economic risk. There's a risk of potential income loss. So when you're thinking about someone who was working at 3 jobs, potentially working, more than 40 hours a week, so they're working at 3 part-time jobs, 50 hours a week at 3 long-term care homes or retirement homes in order to make a living wage, now that they're restricted to a single site, that's a reduction of their income by 2/3. And so in BC, they're one of the provinces that have accounted for the fact that this is happening to this workforce. So they're allowing for compensation for up to 1.3 FTE, so beyond full-time hours, and at one of the higher wages from all the jobs that the employee has, so the worker has. And so they're providing the provision for that. So there's a recognition of the economic risk that this workforce has taken on. And different provinces have implemented these measures to varying degrees. And I think, in Ontario, there's pandemic pay, but there's still, no formal recognition that some of these workers actually work more than full-time hours. So even though you're bringing them on board and compensating them at full-time hours, really, that's a 30% reduction, right, to their salary. And so the varying degrees of risk recognition across the jurisdiction, I think has, not only implication in terms of the retention for the workforce over the pandemic, but I think will also potentially influence the retention of the workforce in a post-pandemic period.
Yeah, absolutely. And I think that's something that that underlying structural issue will still be there. I mean, we're doing well by trying to produce, let's say, more, personal support workers, increasing the pipeline of talent that we can produce for the sector. But there needs to be the other elements of the structure in place in order for the system, the environment to work. So that's very important. I think we have a small technology issue here. I think we lost our guest Amy for a minute. I'll turn to my technical team here and see if we can dial her back, and then we'll go to some questions. I see we have a couple of hands up here. All right, that's when I need some elevator music in the background. Well, I still hope you're enjoying. There we go. We got Amy is coming back. Wonderful.
Apologies for that.
No worries.
One of the downsides of technology.
You may have missed my my last comment, Amy, that it's great that the recognition has been put in place vis-a-vis the compensation, but it can't be just a temporary measure for the pandemic. And if it's not well done, we'll continue to see an erosion or an attrition, because we can produce more, let's say, personal support workers to, for the sector. But if the conditions are not improved, then we may see a continued attrition, and that will continue to exacerbate what we're seeing right now. We do have a hand up, so we'll go to a question here from Jay McLaren. Jay, you can unmute yourself and ask your question to Amy.
Thank you, Claude, and thanks for this opportunity. Amy, your overview is very much appreciated, and it's nice to have that broad perspective that you're providing, so thank you for that. I'm interested in the fact that sadly we have lost many seniors in our LTCs, and that obviously creates vacancies. Is there a resistance on the part of seniors who are eligible to move into these homes now to be reluctant to do so with the high risk? And as a result, does that cost financial stress for the owners, whether they're public or private? And does that in turn reduce the demand for PSWs and care people? It's kind of a a rolling wheel, and the bigger the wheel gets, the harder it is to manage.
Yeah, that's a great question, Jay. Yes. Sorry, I'll let you finish your question in case there were additional thoughts you wanted to share.
No, that's fine. Thank you. I just hope I've made it clear. It's kind of a convoluted question.
No, I think it's a great question. I think, I think one of the things that a lot of individuals in the general public may not realize is that, by definition, long-term care is a care setting where it's a population that cannot be cared for in their own homes. So the supports that we're getting through the publicly funded home care program, and often with the additional help of private sources, so not only the caregivers themselves, so family members, but sometimes also paid private sources, that these are individuals with such complex needs, they cannot be maintained at home. And so long-term care is actually providing a service that cannot be easily met elsewhere. And so I'm not surprised at all that, they were more susceptible to the serious outcome and the mortality that I mentioned earlier, because this is such a frail population that could not be cared for elsewhere. And in fact, in the research that we've done, so we see that in long-term care settings over the course of the pandemic, approximately 30% of the residents who had been infected by COVID-19 had died from the disease. And so that's what we call a case fatality rate. So of the number of cases, what proportion died? And when we looked at the hospitalization records for individuals from long-term care who were transferred to hospital over the course of the first wave of the pandemic, we actually saw that 50% of long-term care residents who were transferred to the hospital had died in an acute care setting. And I don't bring that up because to point out that, there are potential gaps in care, and that's not the case. I bring that up to point out the fact that this is an extremely frail population, and many of them are already at the end of life. So life expectancy of a typical older adult entering long-term care is less than 2 years. So many of them are already in that, in the final months of life. So they're extremely frail. And so in terms of, I think, going back to your question of whether or not there will be attrition or sort of a decline in the number of people needing long-term care, honestly, I think there are ongoing challenges. I think if we are able to provide more support and more funding and resources in a home and community setting, we may be able to support older adults to age at home longer. And we've actually seen that in the veteran population. So I'm involved in this other study where we're looking at veterans' use of long-term care. And we see that with the support that they receive from Veterans Affairs Canada, that enables them to purchase more services, to receive more services from public sources, to remain at home. They actually are entering long-term care at an older age. So they're really there in their last 6 to 12 months of life. But I think ultimately, this is a population that has such complex needs that they cannot age at home and they still need the service. And the care that's provided in long-term care really is holistic and has that perspective of recognizing that these are individuals at the end of life. And there's great palliative and life care being provided in long-term care as well. So I don't really think that there'll be a decrease in need for long-term care, but I do want to I think direct the conversation towards, as we see our population age and we see a higher proportion of older adults in our community, how are we supporting these individuals in the community longer so that there will be less pressure on the long-term care sector, so that when people do need this care, they can receive the care in a timely manner, that we can reduce the wait list for services to long-term care, and people at home can receive care through home care, through community care programs that they need.
That's great. I appreciate your overview. Thank you very much.
Amy, we've got a couple of questions in the Q&A box, and I'll read you one. It goes as follows. Is it possible to filter out the mortality rate in long-term care that would have occurred given the increase in age and comorbidity factors you mentioned earlier?
I'm sorry, I'm not sure I fully understand that question. I don't know if the person who posed the question want to elaborate a little bit more on that point.
Okay, I'm not seeing a hand go up, so okay, we'll ponder that for a minute. Perhaps I'll go to another one here. It goes as follows. I am struck by your comment about the spike in infections when surge capacity was introduced to long-term care homes, and agree that care delivery in the LTC setting is unique and different, partially due to the high proportion of people living with dementia there. I wonder if you saw any difference in the infection rate between the homes that were supported by acute care versus those by the Canadian military. My perception is that these two additional groups provided support differently and at different intensities to the homes that they were involved with.
Yeah, so in my own research, I have not looked explicitly at the outcomes and the supports that are provided in those homes. Some of the experiences I'm sharing is actually from my conversation with long-term care homes that have been impacted by COVID-19. And, I think at the bottom line is that this is a sector that needed a lot of help from the standpoint of staffing, right? So I think whether it was coming from the military, whether it's coming from acute care sectors, and actually, in fact, there were some workers from the home care sectors who were working in some of these part of these teams. They're also providing support in long-term care. So I think it really at the first wave of the pandemic, it was all hands on deck. They really needed the support. And so I don't think, I gave the example of the spike in cases, I think because at the time we were operating with such limited information. I think I was speaking with frontline workers where some of them were saying, well, public health was saying that, we need to wear these gowns when we're providing care. But then they were getting mixed messages from others who were saying, oh, you don't need the gowns, the mask is fine. And, were you supposed to have an N95 mask or a regular surgical mask was okay? So there was a lot of uncertainty. And I think at the time, it was just challenging to navigate and coordinate. So I think for all these homes, the extra help was appreciated. I think that the difficulty that we faced at the time, and this is something I tell all my students, was that a lot of decisions we make during the pandemic is based on the best evidence we have at this time, because we're all new in this. We're all learning from this. And we're going with the best advice from medical professionals, from scientists. We're going with the best evidence that's been produced from research. And we're learning along the way. I think things have changed over time. So it's hard to say whether or not at that time, that was the best strategy or what the outcomes from that. I think we have to continue to evaluate what we've done so we can take the experience from this pandemic and learn from it and apply it to future pandemics. But I think at the end of the day, it really was that there was a recognition of a need for more support in long-term care, and everyone pitched in and really helped the sector to recover from that initial wave.
Thank you, Amy. Another question that picks up a little bit on the announcement that we just heard recently this week from the Ontario government around PSW training. And the question comes from Wayne Johnson, who says, while this is encouraging, one has to wonder if there are jobs available for the graduates. My sense is largely only part-time positions are open. And if true, the only way to deal with this situation is to have great care standards. I was wondering about your thoughts on this.
Yeah, I think the pandemic has certainly forced us to think about the work structure within the sector. I think people get into long-term care because they have a passion to provide care for the elderly. And unfortunately, one of the things that has been highlighted over the course of the pandemic was the challenge in working in long-term care. And I think potentially that could actually, discourage some individuals from entering the sector, just because all they hear from the news and the media is how difficult it is to work in long-term care and how dire the condition is. And I really think that the availability of opportunities to expose individuals to what it really looks like to work in long-term care. And I'm thinking living classrooms through the Algonquin College. I think that's an excellent program to really give trainees the opportunity to see what it looks like in long-term care. And so we recently administered a survey to long-term care workers, trying to understand the impact of the single-site work restriction on the sector. And one of the questions we asked was, why did you pick this particular home to stay at? And, we were thinking, the answers might be along the lines of it's related to the salary, it's related to the support. But overwhelmingly, the response we had received was, this is my home. Almost as if the question, it was a silly question to ask, because they take so much pride in the work that they do and in the care that they provide. And I hear from long-term care workers that, with the single-site work restriction, they wondered about the health of the other residents in another home that they used to provide care to. Right? So they're wondering, I wonder how so-and-so is doing in the other home. And so I think what this tells us is that, I think we need to think about how we're training and providing exposure to long-term care differently to encourage. I think the recruitment of individuals into this workforce cannot solely be on financial incentives. I think people have to understand that this is a really rewarding job, and you have to show, I think, new recruits what it looks like to work in long-term care. Because just with the financial incentive, that doesn't mean they will stay in this workforce or stay in this sector. And in terms of whether or not there will be jobs available, I think not just long-term care, we know there's a shortage of PSWs and frontline workers in the home care sector. So at least in the data and in the trends I've seen, I don't think there'll be a shortage of jobs in healthcare when it comes to care for the elderly.
Okay, thank you, Amy, and thank you for the shout out to Algonquin College. Certainly we take real pride in providing an applied environment for the learning, and anytime we can immerse the learners in the environment in which they'll be working, it really makes a difference in them understanding the parameters of the occupation, and it contributes to their retention in that sector. So pleased to hear that. I'd like to give you, some time. We'll come back. We have some more questions, but I am curious about this project that has been funded by the COVID Immunity Task Force and some of the work that you've done there. If you could talk to us a little bit about that.
Right. So as I think everyone knows, the COVID-19 Immunity Task Force was funded by the federal government to catalyze and support related to looking at the spread of COVID-19 and the prevalence. So the protection against COVID-19, so the immunity against COVID-19 in the general Canadian population, but also specific high-risk subpopulations. So my team and I had recently received funding to look at immunity in long-term care populations. We're collecting data from 3 provinces, so in Quebec, Ontario, and British Columbia. So we're going into long-term care homes to collect blood samples from long-term care workers, as well as residents, to look at their immunity from COVID-19. So initially, when the proposal was developed, this was before the vaccine approval and rollout. The question was, how much natural immunity can you gain from COVID-19 infection? And of course, with pretty much everyone in long-term care, at least the residents are vaccinated, now the question has shifted towards vaccine effectiveness. Mm-hmm. So I think one of the lingering questions from the clinical trials is the long-term outcomes and the long-term effect of the vaccines. And so, all the manufacturers are continuing to do that. But one thing that I've pointed out multiple times in my presentations is that the populations that are recruited into those studies, even though they do include older adults, they're older adults in a community setting. As I pointed out earlier in our conversation, a fairly robust 80-year-old person living in a community with 2 or 3 comorbidity is very different than a 90-year-old with 7 or more comorbidities living in long-term care. So with concerns about immunosenescence and the ability of this frail population to generate a high enough antibody response to become immune to COVID-19, I think there has to be more study around that. And that's actually exactly what we're doing with the COVID-19 Immunity Task Force funded project. So we're hoping to collect data at several time points over the next year, essentially extending that trial structure where we're looking at immunity at 1 month, 3 months, 6 months, and 12 months post-vaccination, and looking at their antibody response. But on top of that, we're building infrastructure that allows us to collect these blood samples that not only allow researchers to study your antibody response to the current strains of COVID-19, but as we're hearing about these new variants, we can also test individuals who have been vaccinated and their antibody against these new variants. So we're actually building capacity and providing information to long-term care, which is information they didn't have in the first wave of the pandemic and for most of the second wave. So in the third wave, they'll be even better prepared to deal with the impact of COVID-19 on this population.
Thank you, Amy. Exciting research and very important research to be done, absolutely. We do have one live question here that I'll go to. It's from Audrey Lawrence. Audrey, you can unmute yourself and ask your question to Amy.
Great. Thank you, Amy. This has been a fantastic presentation, and your information rings true with what I already know, and I've learned a whole bunch more. And I really wanted to thank you for giving a good shout out to the people who work in long-term care, because they really do care about their clients. My previous husband was in long-term care, and many of them came by when they knew he was dying to wish him well, to see him before he passed away. Even though they were off shift and an hour late from going home, they took the time to do things like that. One thing I just wanted to comment on, because we've been talking a lot about staffing, but when my husband was in long-term care, I used to spend many hours every day going in and feeding him and feeding the other patients, sort of the residents at the same table, because it took him a long time to swallow. So I would do 3 other people and then feed him again. And when this happened, of course, all family members and friends were not allowed into the facilities again for months. And I think many of the staff members did not appreciate how much extra support they had been getting from this service that friends and families do extra for these people in long-term care who have so many, as you say, issues and needs. And I was wondering if you see a mechanism where there might be some protocol where a family member or a caregiver can, because not everyone can afford a paid caregiver to be on the facility that has the training. I know they were allowed back in much earlier. Just would appreciate your thoughts on that.
Yeah, I appreciate that, Audrey. And I think actually long-term care, many long-term care staff and administrators do recognize the contribution of family members. I think one of the challenges, at least that I'm aware of, is with our legislation around, the different healthcare professionals around the sector, the home actually assumes a liability, I think, when something happens to the residents. And I think, often you have workers and volunteers who are providing care, and if something were to happen to the resident, then the home have to take on the responsibility for that. So I think we need to think about how the current legislation is actually set up, and whether that's actually helping the services that we're providing, the care we're providing in the long-term care sector. But there are also actually initiatives, and in fact, initiatives are led out of the Ontario Centre for Learning, Research and Innovation, the CRI, where they're partnering with long-term care homes to provide training to designated care providers. So family members, substitute decision makers, other loved ones, relatives who want to provide support to those in long-term care. So then now they'll receive formal training. And I think it helps to mitigate some of the risks that I think some of the homes are potentially afraid to take on when you have a lot of visitors and people coming in and providing support and care in long-term care settings. And so there are now these programs being rolled out across Ontario. This was initially piloted in the hospital setting, where designated caregivers will now receive a little ID card saying, I've received the training, I can provide support, I can lend a hand in a way that it's more formalized. And I think not only helps the caregivers to become more engaged, but I think this is potentially another avenue where we can think about how do we continue to provide resources to support the care needs of population in this setting. And so one of these ways is potentially by utilizing volunteers and caregivers who are already there, right? I started my career as a volunteer in a long-term care home. And, I think, and then I ended up being a trainer for volunteers. And I think people don't realize how much training is required. You can't walk into the long-term care home and be comfortable with a job in even just a month or two. I think understanding the needs of this population, that takes time. And so maybe it's time we start thinking about how do we provide more formal training to people who have the desire to provide support and give them more formalized support and training so that they could be more involved.
Thank you for that answer, Amy, because I don't think a lot of caregivers, I understand that the need for the structural one, but I think a lot of caregivers don't understand those structural barriers, and it wasn't given to them as information. So they just thought they felt shut out, and getting this message out of the need for further training or identification of extra resources that can go through a process like that will be very helpful in the future. So I think that's great answer. Terrific. Thank you.
Thank you, Audrey. I'll go to one question, Amy, from our Q&A from Keith Eagleye. He says, we've heard a lot of discussion in the province around providing a more sustainable paid sick leave program. And do you think if this was available, it would have made a difference in the rate of transmission in long-term care homes?
Yeah, I think it goes back to my earlier point about the recognition of the economic risk that people take on. So I think with the paid sick leave, you see this interaction, this collision of that health risk with that economic risk. And we do hear, even in the current vaccine rollout, it's challenging for some long-term care workers to become vaccinated if they're not working at a second home, but they may have picked up a second job, as an essential worker in a grocery store. So they're traveling between work sites. So where in your day do you find the time to go, make a trip to, in this case, the Ottawa hospital, which may be out of their way, to line up, to be vaccinated, and then travel to your next job. So I think it is very difficult. And I think that the provision of paid sick leave for this sector is absolutely essential. I think it's something that we need to discuss. I think as a province, it's not an issue that's limited to just private providers. It's an issue that we also see a challenge in public providers as well. It's a sector-wide issue, and I think this is something that has to be dealt with at the provincial level. So thank you for bringing up that point.
Mm-hmm. Thank you, Amy. And we have a couple of minutes left, and it'd be great to end on a high note. Notice Guy Chartrand put it in the chat, and my last question was pretty well aligned with what he's asking as well. So I'll combine the two together. His comment or his question is, what would be your top 3 things that you would advise or suggest that we focus on as we work towards better system design that is respectful of our elders and provides a safer environment so that the sector can regain confidence for our residents and their family? In other words, what are the opportunities? Where are those opportunities for long-term care?
So I think at the top of my list would be support for the workforce. I think if you have a workforce that is well supported, so people who come to work, they feel safe at work, they feel like they could do their job productively and optimally, they're going to naturally provide better care to their residents. So I think it's so important for us to provide additional support to the workforce, not just financial. I'm also thinking about the mental health and well-being supports that's needed by folks in the sector. I think a lot of people don't realize that there is a very strong bond between the workforce and people who work in the sector and the resident they provide care to. And to repeatedly see resident you're caring for fall ill to the disease and potentially die from the disease, the grief and the need for bereavement is something that hasn't been highlighted, I think, in a lot of our current conversation. So that support for a workforce, I think research, policy, that's an important issue. I think another area that we haven't really touched on in this conversation is the clinical care. I think the challenges with providing care to a dementia population has to be addressed. So we know that there's an increasing proportion of people coming in with multiple comorbidities, but there's also increasing proportion of people coming into long-term care with dementia. And there are very unique challenges to caring for this population. And we haven't invested enough resources to provide more training for people to think about dementia care and also palliative care actually in this setting. And so I think there needs to be more clinical training and support for clinical training in those areas. And I think there's tons of research and thinking about how we can improve quality of life and care for that population. And of course, I think finally, there's so many aspects to the design of long-term care that we're now all reflecting on. Now, long-term care has inherited its physical structures, some of it from hospital settings, some of it actually were initially infrastructure that were built as shelters or housing for the poor. And when we look at the history of nursing homes and long-term care about 100 years ago. And so a lot of them are not physically designed to be an environment when a person can age with in place and with high quality of life. So now we're thinking about how we're designing and redesigning this long-term care setting. I think it's really important to think about how we're even setting up the environment to minimize transmission of infectious diseases in the setting in the future, but also maintain a home-like environment because it's not a hospital. People live in this environment. So how do we balance those two? And there's a number of promising, I think, research coming out that innovative research coming out of that area. I think about design and long-term care that I'm very inspired by, and I think that's a direction we should explore further.
And currently, certainly, from what I'm told anyway, that the dollars that are assigned to a long-term care bed for a license are not representative of what you're speaking of, right? We need to rethink the design, but we also need to fund it appropriately. How would we go about being able to do that?
Yeah, if you look at the change in per diem funding for long-term care, it has essentially increased at the same rate as inflation. And we all know that with inflation, it just covers the cost of living, the cost of the rise in prices and material goods over time. It doesn't actually factor in that on top of that, there's that increase in care needs, right? So on top of what you're paying, you actually need to factor in that there's now more training there's now greater care needs, there's now more need for resources. And so funding on the per diem basis from the province has to match that proportional increase in care needs, not just increase in the cost to actually purchase supplies and pay individuals' wages. And so I think that's a conversation we need to have at the provincial level, and we have to hold our elected officials accountable to that if we want to see change in long-term, not a one-time investment into training of PSWs, you need to see that sustained investment into providing care in the sector.
Yeah, I couldn't agree with you more. It's this is about sustainability of the system in the end, right? We need to make sure that all the actions that are taken allows the system to be able to see to the future needs, not just fix the current issue that we're facing right now. Well, Amy, I know we have a few more questions that have been posed. We won't have time to get through them all. I'm so encouraged by how much our audience really enjoyed your presentations, the thoughts that you've brought to our conversation this morning. It's such an important topic, a sad topic at times because of what we've seen taking place, the tragedies that we've seen in the sector. At the same time, the research that you and your teams have been able to shed a light on is providing hope that we will see change, sustainable change in the future in such a very complex environment. We want to make sure that our frail older population are able to live comfortably with dignity as long as possible in their homes, and that when that's no longer possible, that they have the right care, the most appropriate care in our long-term care setting. So I want to thank you, Amy, on behalf of our Board of Governors, myself, and all of our audience for your participation. We really appreciated you sharing your insights and your knowledge. And certainly today's conversation gave us a lot to think about, and we're delighted that you were here with us for this conversation.
It's my pleasure. Thank you for having me.
So this concludes our event for today. Please note that you can view all of our healthy living education and our future of health and wellness speaker presentations, including this one, online at the website on the screen. Or you can find the links on our Algonquin College Healthy Living Education website. In any case, if you have trouble finding the links, just send us an email. We'll be more than happy to help you. I would also like to thank you, our audience, for starting your day with us. And I look forward to seeing all of you back here on the 20th of April, when we will have our next virtual Future of Health and Wellness speaker series. And that one will feature Dr. Jessica Hopkins, who's the Deputy Chief at Public Health Ontario. Details will be coming out soon, so watch your inbox for this email from us. Once again, thank you for sharing your morning with us, and thank you, Amy, for a great conversation. Thank you,